Welcome to Hangin at the Reef. I'm your host, Jeffrey Rich, and today we have two special guests who have made lasting contributions to the physician assistant, or PA, profession. First, we're joined by Dr. Alfred Sadler, MD, a pioneering figure in the development of the PA profession. In the late 1960s, while serving in the U.S. Public Health Service at NIH, Dr. Sadler, along with his twin brother Blair, a lawyer, researched the use of physician assistants to address the growing physician shortage following the introduction of Medicare and Medicaid. Their groundbreaking work led to amendments in state medical practice acts, which allowed PAs to begin practicing. Dr. Sadler went on to develop one of the first PA training programs at Yale Medical School, where he co-authored The Physician's Assistant, Today and Tomorrow. Dr. Sadler also served as the founding president of the Association of Physician Assistant Programs. In 2014, he co-founded a PA program at California State University, Monterey Bay. Throughout his career, Dr. Sadler has made significant contributions to primary care practice, medical ethics, emergency medicine, and healthcare policy, influencing both PA education and practice. His recent book, Pluck, was written with his brother Blair. Also joining us today is Cynthia Lord, a highly respected PA educator with over 29 years of experience in both clinical practice and academia. Cynthia played a key role in developing the Quinnipiac University PA program and went on to become the founding director of the Case Western Reserve University PA program, where she also served as program director for 7 years. Throughout her career, Cynthia has been dedicated to advancing primary care, interprofessional education, and oral health integration into healthcare curricula. She is a passionate advocate for improving access to dental care and has held leadership roles in organizations like the American Academy of Physician Assistants and the Connecticut Academy of Physician Assistants. Cynthia's dedication to teaching, mentorship, and community service has earned her numerous awards and recognition in the PA profession. We're excited to dive into their inspiring stories and hear their insights on the history and future of the PA profession. Welcome to today's episode of Hangin at the Reef. Today, we are diving deep into one of the fastest growing and most impactful fields in healthcare, the physician assistant, or PA profession. With over 170,000 PAs practicing across the United States, the PA profession is an essential part of our healthcare landscape. In Hawaii, this field is growing rapidly, thanks in part to the first Hawaii-based PA program offered by Hawaii Pacific University. It's helping to meet local demand and satisfy healthcare shortages across the state. To help us understand the origins, growth, and evolving significance of the PA profession, I am thrilled to introduce Dr. Alfred Sadler, a pioneering leader in the PA field, and Cynthia Lord, a practicing PA with deep experience in clinical practice and PA education. Dr. Sadler and Cynthia, thank you both for joining us and welcome to the show.
Thanks for having us.
Glad to be with you.
So, let's start for our listeners that aren't at all familiar with what a PA is. Maybe Dr. Sadler, could you just give a brief explanation of what a PA is and what a PA does?
Yes, a PA, or physician's assistant, sometimes called physician's associate, is a licensed practitioner who has been trained in medicine to practice medicine as part of a team with physicians. And they do much of what a physician does, but with the collaboration of physicians in everything from primary care to subspecialty medicine. There are now, as you said, 175,000 PAs across the country doing some aspect of medicine.
It's clear that, PAs are an integral part of healthcare teams. They work alongside physicians and surgeons and other providers to ensure comprehensive care. Given the collaborative approach of the profession, what are some of the ways in which PAs complement a physician?
We always joke about the interprofessionality of the PA program. We were doing interprofessional long before it was the hot buzzword. But PAs work alongside their physicians, but it doesn't mean that they're in the room with us. So a PA in a cardiology practice might do the intake and see new patients. And so they perform histories and physicals. They can make diagnoses. They can prescribe. In some places, the PAs may do the admission history and physical for a patient entering the hospital, or it may be the PA who does the follow-up. So PAs can fit in anywhere in the world of medicine where a physician might see a patient, and in any place or time that they might see them. It just depends on the relationship of the PA with their collaborating physician.
That really helps our listeners understand what a PA does. Let's take a step back, though. So the PA profession really emerged in the 1960s, and it was in response to a shortage of physicians, the expansion of healthcare programs such as Medicare and Medicaid. And now, I know, Dr. Sadler, you were closely involved in those early days of the PA profession. Can you walk us through its origins and tell us about how this profession has emerged and what needs it was initially designed to address?
Be glad to. It takes me back to the very exciting time in the mid 60s when Medicare, which is we sort of take for granted now, is pays for care for 65 and older folks, and Medicaid, when it's called Medi-Cal here and where I live in California, is for a poor population below a certain income level. And these were adopted in 1965. Lyndon Johnson was president, and implemented in 1966. There were some very forward-looking physicians who had had experience with non-physicians and saw what could be done in the military corpsman capacity, for example, in Korea and then in Vietnam. Vietnam was just starting to heat up, and saw, as well as examples in private practice in civilian life, where very bright people working in doctors' offices would be taught to do more and more some of the things that Cindy mentioned PAs do now. They were taught kind of on the job. So with that kind of background, Dr. Gene Stead at Duke, who was chairman of medicine and had experience with corpsmen, as they were called, military corpsmen, and saw, why don't we use these people who were coming out of the military? At this point, it was Vietnam, but he also had helped with the Korean situation, where corpsmen were right on the battlefield, saving lives with bullets flying over their head often. And then they also helped out in the operating suites at the base hospital. So they had this broad range of experience. They were trained first in the military. So they had a basic year to year and a half training at places like Walter Reed, or in Texas at Fort Sam Houston, for example. And so they built on this. They came back to civilian life, and there really was no comparable job for them. So most of them were lost to healthcare completely with all this training, or they could be an orderly, let's say, and work way beneath their skills. And he decided to let's build on that knowledge and experience. And he built a curriculum that looked a little like a mini medical school, a lot like a little mini medical school. And over a 24-month period, teach them to become what he called physician's assistants. The first class of 3 was graduated in October of 1967. And so that's considered the birth of the PA profession. Meanwhile, there were 2 other leaders. There were actually more than 2, but I'll mention 2 others. There's Dr. Henry Silver in Colorado, who's a pediatrician, and he, working with his nursing colleagues, saw that a lot of what the nurses did in the community clinics was very simple and routinized. They could do a lot more. They could diagnose and treat. So he started something called a nurse practitioner program, evolved into a higher level called the Child Health Associate program in 1969. And he and Dr. Stead were very close colleagues. And then the third great leader was Dr. Richard Smith, who was in the Peace Corps and saw abroad what other countries were doing in the way of using non-physicians. These were really basic positions that did not require a lot of medical background, but they did a tremendous amount of getting care out to the rural areas, for example, or getting patients back to, and he thought, let's build on that. And so he started a program in Seattle, Washington, at the University of Washington in 1969. So those are the pioneers that took this existing workforce. And then as the PA profession got known, then people who were previously nurses or had some other background or maybe had worked as a volunteer in a healthcare setting decided, PA, that looks like something I could do. That would be very interesting.
Well, every new profession faces challenges, and I know the PA field was no exception. Could you both share some of the initial hurdles that the PA profession had to overcome, particularly as it relates to things like licensure and credentialing?
Well, I'll stay on the licensure credentialing issue because my twin brother Blair is a lawyer and I were working on medical legal issues at the National Institutes of Health in the late 60s. And we were asked by the Assistant Secretary of Health if we would look at these pioneering programs in 1968. So we had a chance to go out and see the three programs I just mentioned. And they were starting to say, what are we going to do to credential and license these people? We are concerned because there was a moratorium on new health professions being licensed at that time. So we worked with our colleagues at Duke and we came up with the idea of a delegation amendment to the Medical Practice Act, which put PAs right under the practice of medicine by saying, when it defined what a physician could do and what their limits and responsibilities were, operate, diagnose, treat, and prescribe were the four principal physician-only words. That there's a paragraph we added which simply said, nothing in the above language shall prevent said physician from delegating to a specially trained assistant those tasks which he or she is responsible for, and they both would be responsible legally. And that was the law that then allowed PAs to practice throughout the 70s. It went through about 30 states in about 5 years because it was so simple. And we brought in the Federation of State Medical Boards, which is an organization of all the licensing boards of all the 50 states. Because to be a licensed physician or nurse, that's a state thing. That's not a federal thing. So you had to get 50 different laws passed. And we worked by working with them. They saw, yes, the physician will still be in charge here. And Dr. Stead famously said that we want the PAs to be dependent legally to physicians, because if they are, then as they get more experience working with that doctor or that clinic or that hospital, they can do more and more because they're both responsible. But if you made them into an independent practitioner, you would have to define their scope of practice, and that would be very narrow compared with given 2 years of education versus 8 years of physician education.
I was going to just add, it sounds like the objective was to really make a PA integral and collaborative with a physician. And in some of the early conversations, it sounds like there was, discussion over if a PA would be more of a competitor almost to a physician with areas of specialization. Was that a part of the conversation, or was it always meant to be a collaborative role that worked at the direction and in a strong integrated fashion with the medical doctor?
I guess I would say both and. The feeling was much the way the highly skilled corpsmen, and they were called independent duty corpsmen, the most advanced corpsmen, would actually be on, say, a battleship as the only medical provider. So there they were. So there was a precedent for having corpsmen by themselves without a physician around. And certainly when they're out on the battlefield, they were by themselves. And so the thought was there might be a setting like a rural area where there was no physician and there's a desperate need. But the idea principally was a collaborative one, recognizing that there are so many different roles that physicians play. So similarly, there will be many parallel roles that PAs can play.
Got it. And Cindy, from your point of view, what were some of the early challenges that you saw in the profession, and what challenges may still exist today?
So I think probably one of the earliest and continues to be a topic of conversation is our name. So just call me PA, but in the early formative years of our profession, the title physician associate, which Dr. Sadler and myself are both Yale grads. Yale has never changed. It was always a physician and is a physician associate program. But some physicians who weren't familiar, this was a whole new profession, were concerned about that title associate, and that a PA was not actually the associate of a physician, kind of taking that term literally. We've had over the past 60 years had that conversation. That conversation continues. Recently, in the last 2 years, our professional organization, the American Academy of PAs, has moved to adopt or readopt the title of, instead of physician assistant, physician associate. And we went through a period of just call me PA, because most people just call you a PA. So that always, and even the word physician associate or physician assistant, no S. Some people will say physicians, and it's not possessive. So that the title has always been a hot topic of discussion, and continues to be. But in real life, in practice, patients are very comfortable with the PA, whatever they call themselves, physician assistant or physician associate. One of the other early, I wouldn't say challenge, but it was the concept. You talked about maybe that little bit of competition. Would physicians feel comfortable with another type of provider doing some of their roles and filling some of their roles and responsibilities? The concept that Dr. Stead and others came up with, it wasn't just collaboration, it was this mentorship, that PAs were designed to go into more rural areas, do primary care, again, to fill that need that was being brought on by the addition of Medicaid and Medicare. Like there was going to be this influx of people now, older people that had insurance, and they were going to need care. But the physician would hire a PA, and in those days, most PAs were in more private practice. Private practice existed. Everything wasn't a large healthcare system. And so there was a mentorship and really that's actually how I was trained. I'm a third generation, an 80s PA. So I grew up with, when I did my clerkships, you worked right with the physician, you worked right alongside of him. And then when I was hired in primary care, where I've stayed my whole life, I mentored up with my physician, and that was the goal, that it was like an in-house residency that I mentored up with and learned the way my physician colleagues work. I had 3 physicians that I worked with, and I learned from each of them, and that's how I learned medicine. That's how I practice medicine today, and that we became ultimately colleagues and almost equals. And in my private practice, my second practice, which was the last one I had before I am where I am now, like the doc, Bert would knock on my door and say, "Hey, Cyn, you do women's healthcare. Can you come see this patient?" And in the same breath, I'd say, "You know what? Can you see my patient with diabetes? I've maxed out where I am with them, and I need some help tweaking their treatment plan." And so we could really just interchange and exchange ideas and thoughts on patients within the same sentence. And that was really the goal. Not to just shove a bunch of people out there and have a doctor overseeing them or being in the room with them. And that was also, a challenge when you say dependent practitioner. Does the physician need to be in the room? Do they need to be on site? And in most good legislation, it was in those days considered telecommunication, as long as they were a phone call or some kind of communication away, so that a PA could be in the northern outpost of Alaska, and maybe their supervising, or now called collaborating physician, might fly in once a week, but they could talk to them at any point. They could radio in or talk to them.
Clearly, healthcare needs have evolved over time, going back to the origins of the PA industry back in the 60s. And then you've already given some examples of how the PA profession has started to evolve to keep up with the changing needs of healthcare. You mentioned early days of the PA profession, the role was focused more on primary or general care, and has evolved more to a point now where there's a PA involved in nearly every specialty. Can you give us some more examples of ways that PAs have expanded out from that initial challenge of primary care and how they now are playing vital roles in all forms of healthcare delivery and different areas of specialization?
Sure. I'd like to start with, I think my favorite example is if you go back to the year 2000, when the Institute of Medicine, now known as the National Academy, put out their Sentinel report on patient safety called To Err is Human. And in that report, they identified the fact that medical residents, it just probably wasn't healthy and safe for them or for patient care to have these residents, doctors in training, working excessive hundreds of hours without sleep and all that responsibility. And they were tired, and maybe accidents could happen. We talk about patient safety and errors. And so there was a panic when the graduate medical education, GME, said, well, okay, we're going to do this and we're going to cut 40 hours. They can't be on more than 40 hours or not 80 hours. They had their 80-hour, they had their rule. And then, of course, attending physicians were like, okay, that works for me. It was the nurses, on the floors who then said, well, who will be here? If there's no resident here in the middle of the night and on the weekends, who's going to be here? And I will say that seamlessly, without changing our credential, without changing our educational model, without changing how we practice, PAs slipped into that role, and the specialty of medicine, or the discipline of medicine, now known as hospitalist medicine, evolved. So you had, and Yale New Haven Hospital was one of the pioneers in that area, where they had physicians who were lead hospitalists, and under them they had a number of PAs who provided care to patients, so they could take care of large groups of patients. They covered nights, they covered weekends when residents may not be there, and worked alongside by side with residents when they were there. So again, more collaboration, interprofessionality, but we filled in that role. Jump forward to 2009, and we realized, wow, we took the head off the body. We don't do mental and we don't do dental, and two crises in our country are oral health and mental health. And again, without a change in licensure, credentialing, training, education, PAs slipped into those roles, and PAs took on oral health and were trained to look in the mouth and to make that relationship and that bi-directional referral with a dentist, the same way they would call a dermatologist or a cardiologist. PAs are now in mental health, in all aspects of mental health. Substance use disorder, when the opioid crisis came on, PAs just included it and integrated it into their curriculum. It was there, they just enhanced it. And so they've been able to adapt on a moment's notice as the world of healthcare has changed. And I'm sure Dr. Sadler can add to that.
Those are some great examples. And one of the things that labels that's been applied to the PA education is that they're like a stem cell. And you hear that in science, that stem cells can then differentiate into all kinds of specialty cells. And the curriculum still at 24 months, many programs are 28 months long, and they've evolved to a master's degree in addition to the original certificate, because we didn't feel that a degree was essential compared to getting a certificate of competency. But that people get this same core training in the 310 PA programs around the country. And there's an accreditation body that we set up in the early 70s with the medical profession that looks to see that what is taught is universal. And then if one of us comes out as a graduate of a PA program, we can go into primary care. But if we've expressed an interest or fallen in love with surgery or dermatology or oral health or mental health, for that matter, we might go directly from our graduate celebration into working with a psychiatrist, for example. And then I think the other thing that's important is that there's flexibility once you've made that decision. If you decide after 10 years, this is really not my field, or I'd like to look at that bright, shiny object across the street called orthopedics or, some other field, you can negotiate with the clinic or the physician and start out. Now, when you first start out, in orthopedics, to use that example, you would be very closely supervised. And then over the next year, you would be allowed to do more and more. And Cindy and I were talking about this today. She reminded me that the average PA changes career 3 different times during the course of their career, which makes it for a very rich, interesting, stimulating profession for the practitioner. Physicians don't have that luxury because once they specialize, they pretty much stay in that one area.
It's probably kept us at a lower burnout rate than other health professions fields. We range in the happiness when they've done surveys of PAs and looked at happiness. And would you do it again? Or would you definitely do it again? 82 to 96% of PAs say they would do it again because, you can get to a point where like, working all this time in the ED, I really need a different type of career, a different type of discipline now because I have a family or just their needs change. And so our ability to have that lateral mobility, and I think had to be able to keep it for all these years without changing, everyone scratching their head with our educational model, which is so unique, and still being able to have that lateral mobility is pretty special.
Well, I like the analogy that Dr. Sadler used, referring to PAs as the medical stem cells of healthcare. That's a very appropriate way to sort of phrase the profession as sort of a nucleus or a point of origin. And you mentioned the adaptability of the profession. So as you used examples such as extending into mental health or dental, is a PA functioning in a similar way as an MD might to have training and the ability to observe issues with dental or medical and then make referrals to other specialists? Or are PAs in some cases extending care into those areas based on training?
Yeah, no, PAs are actually working in those areas and extending care into those areas. Um, I had a colleague who was working in surgery and they really admired her, and her collaborating physician wanted to start a surgical ICU. This was many, many years ago, and decided they didn't want it resident run because residents rotate through and there wouldn't be stability. And they felt for a surgical ICU needed continuity of care. And so they developed a surgical ICU. She was the head of it. He was the collaborating physician. And they had it staffed all by PAs. Residents rotated through there, and the PAs taught the residents about the care of, the surgical critically care patient. So you see PAs today now in every discipline in medicine, from, again, primary care to I only do right hand surgery. But PAs are in leadership roles, they're in administrative roles, they're in advocacy. They're in politics. We have a PA who was in Congress and is now the mayor of a very large city on the West Coast. So we see PAs expanding their role. They're in the C-suite, in those management roles. PAs were always kind of the worker bees on the floors in the offices, and now we see them in those management roles as well. They work for healthcare systems and payers like insurance companies making those decisions. And again, our bond with medicine, with physicians, has stayed strong. Unlike other professions, we've valued that relationship, that back and forth, that mentorship, and we've respected the profession, the physician profession, and so we haven't felt threatened because we're colleagues, we work together, and we're comfortable in our own skin.
You mentioned earlier patient safety, and that's always a priority. With such a broad potential purview for PAs extending into so many different areas of healthcare, how is patient safety guarded against and a defining of the PA's scope of practice?
Well, I think that's done in a common sense way, in that if and based on what we talked about earlier from the very beginning, that you're working within the physician's scope of practice, or in the case that Cindy just mentioned of an surgical ICU, you're not delivering babies in the surgical ICU. You're staying within the scope of practice of the ICU. So there's a natural limit, which is really similar to what there is for physicians. Now, that's not to say that what Cindy is doing in family practice now is identical to what she did 10 years ago. I'm a general internist. Well, I've had a number of different roles in general internal medicine, with a small group practice, then an urgent care, and as I evolved, my scope of practice changed. How does that stay safe? I think we have a Hippocratic oath in medicine. There's a similar oath that the PAs take to be uh, primarily concerned with patient care and patient safety. And Cindy can probably recite it from memory, but so the point is that it's the ethos of PAs is exactly the same as the ethos of physicians, and they're not. That's not to say there aren't some physicians or PAs that are more strictly adherent to it, but certainly that's what has kept um, the profession of the PA profession from getting out of hand. I think the other important thing going back to history that's carried right through is when it came to examining uh, a PA. So PA graduates and they have the certificate from Yale or wherever that they had this great education and did well. But just like physicians and other health professions, you have to take an exam to prove that you know the appropriate amount that is needed to be a nurse or a physician or a PA. And we worked in the early 70s with the National Board of Medical Examiners. And it's really important to mention that because they had only examined physicians before, medical students, and then the specialty physicians, founded in 1915. So a group of us got together with their leadership in Philadelphia, where they've always been headquartered, and put together the first national PA exam in 1973. And so every year it was given by the NBME, and then eventually a national commission was formed, which was eventually moved to Atlanta, Georgia. But I think it's another example of the close tie between medicine and the PA profession, that they're even examined by the same organization.
State practice acts give you a general umbrella of what you can do as a PA, but part of those state laws, most states have implemented a piece that says it's really that's kind of an umbrella, but then it's determined at the bedside with the physician. So a physician who has a brand new grad is going to supervise and watch them and collaborate with them much closer than somebody like myself who's been doing this close to 40 years, right? So when I first started, my docs read every note, they signed off, we met daily to talk about patients, and now they pick selected charts. We get chart reviews so often in the year. So it really it was designed so that the physician, the collaborating physician, would look at their PAs, and there could be 6 PAs that have been working for 30 years, but they may be at different levels depending on their expertise and knowledge. So that's a very unique relationship as well with our physicians and in a way to practice medicine, but it does safeguard patients. And as Dr. Sadler said, not only do we take our board exam to get certified as a PA. That's what the C after PA is, where the hyphen C. But we need continuing education, as physicians do. Every 2 years, we need to gain 100 hours of continuing medical education. And every 10 years, I'm in my 10th year coming up, we reboard certify. And you reboard as a generalist. So you could be practicing in plastic surgery for 40 years, but every 10 years, you're taking an exam that asks you about kids, that asks you primary care, surgery. So that again allows us that lateral mobility and allows us and provides us with that, coverage of some safety that we've stayed up to date with the practice of medicine.
You mentioned earlier the PA ethos, which is built around interprofessionalism, interdisciplinary medicine, integrative medicine, call it what you will, but it's built around collaboration at the end of the day. So with teamwork and collaboration at the core of what a PA is, and Cindy, you just mentioned some ongoing ways that PAs stay up to date on training, but going back to the origins of a PA training to become a professional, what are some of the principles that are taught that sort of emphasize the process of collaboration with other practitioners in the medical field. Because when I think about contemporary models of healthcare delivery, I think of, things that are highly effective, like at the Mayo Clinic, for example, where it's a team of medical professionals that approach a patient in a fully integrated capacity versus, a general care practitioner or a specialist. How is training in the PA profession staying current with this collaborative approach to healthcare that's becoming so important, to have multidisciplinary perspectives on a patient's situation?
Well, wearing my PA educator hat for almost 30 years, our accrediting body, the ARCPA, the standards for accreditation of a PA program and for ongoing continuing accreditation specifically state, it's not buried, it's specifically stated that we must have education and training in interprofessionalism. And that doesn't just mean you bring the doctor and the nurse in, hi, I'm a doctor, here's what I do, I'm the nurse. You not only have to learn who the different players are, but you actually have to train with them. So it's actually either in the field or clinically or in team-based interactions, whether it's simulation or in clinical rotations, students have to have interprofessional experiences and they follow the IPEC competencies. So they must learn values and ethics, roles and responsibilities, teamwork, interprofessional communication and collaboration. Those are all mandated as part of the curricular components in both the preclinical or the academic phase, as well as the clinical phase of a PA's education and training.
So, from your experience, Cindy, how does this team-based approach affect patient outcomes and the overall delivery of healthcare?
So there are studies out there with PAs and or nurse practitioners with physician collaboration that show that it's improved, that patient safety has improved. You have 4 sets of eyes on the patient. The communication is better. Again, PAs being interprofessional, that's just our nature. So we read nurses' notes and then we'll go to the physician and say, did you read the nurse's note from last night? X, Y, or Z happened. We're not afraid to pick up the phone and call the dentist. So a lot of times that PA, they used to call extender, but we are really the connection with a lot of other health professionals and the physician because we're just comfortable doing that. And we're trained to think that way. Call physical therapy, call nutrition, who knows medications best? It's the pharmacist. So PAs, oftentimes that's their role to make sure everyone's connected, connect all the dots and connect it back to the physician. So the patient is in the center, like a spoke of the wheel, the patient is in the center and all of those different health professionals are the spokes of the wheel connected. So that provides patient-centered care and improves patient safety.
The word interdependence comes to mind when you think about the PA and physician relationship. How do you look at interdependence among these two roles versus collaborative? When you think about how the interdependence of a PA and a physician are central to the outcomes and the patient experience, what is it that makes those roles so interdependent versus complementary to each other?
Well, I think that is such a crucial point. I think in many ways, collaboration and interdependence are very similar words and have very similar meanings, but interdependence is, you hit the nail on the head with that, and that in some areas, a PA may be operating essentially independently from the physician. There may be a string of clinics, for example, of 3 or 4 clinics, and a PA is by him or herself at that clinic. And then that's quite independent. Another place, they're the surgeon's chief assistant. When I had my 2 knees replaced, it was an orthopedic surgeon and a PA. It wasn't 2 orthopedic surgeons. And so they're just like this. And that's true of PAs in surgery in general. But they also will do pre-op care and post-op care, and depending on whether there's a hospitalist service. So this interdependence gives us, I think, it's the best term. And Stephen Covey, when he wrote his addition to the 7 Habits of Highly Successful People, he came out with a second edition 20 years later. and had the eighth success word, and he has it's just beautiful. On the opening page of his book, there's one sentence on it. It says, interdependence is more important than independence. And then it gets into his book and he explains why that is. When you think of how we function as a society, we're very interdependent, aren't we? And I think when people lose that perspective and that community collaborative perspective, then we get into trouble and we get into fights and competition. And so I think the word interdependent is something that we should all be living by throughout our various interactions, whether it's going to church or going to school or helping in healthcare.
Let's talk a bit about the global impact of the PA profession. So, the PA model has gained traction internationally. What do you think has driven the adoption of the PA profession in countries like the UK, Canada, and Australia?
I think very much the same drivers as here. They're producing physicians is a very expensive, long time process. And when they saw what we had done, or they may have had some experience in their own country with uh, advanced nurses or advanced practitioners who were not physicians, and they thought, well, let's look at this US model. So we have, over the decades, we've had people come and follow our testing example, come to Cindy's school at Case Western Reserve or at Quinnipiac or at Yale and say, let me spend 3 days with you and show us how you teach. So that's how the whole US model spread. Now, depending on how healthcare is funded, and most of the developed countries have a national health service of some kind or another, then there are very different rules about payment and who's in charge, that sort of thing. But if you go to Africa, it tends to be more of the original model that Dick Smith had, where the course of study is much shorter and they're not expected to do anywhere near as much in the way of diagnosing and treating, but really get medicine out to patients, get patients in to be seen at clinics. So there are various levels of support. And Cindy, please add to that in any way you want.
No, I agree with you. And, it's interesting because our roots actually, we weren't the first. We took our lead from, there was the barefoot doctor in China, there were the Felchers in Russia. So those early kind of pre-PA models did give Stead and Silver and Dick Smith ideas. And we just did it really well in the United States. Our physician leaders, they really did a great job with the profession. And then that's kind of circled around now to other countries, developed countries. Canada, for instance, they really kind of followed us. They were thoughtful, they were slow. They came to our national meetings. They went to PA programs, as Dr. Sadler said, but they started their first program in the military and said we can control that. And then they went out into the colleges. So different countries have done it in different manners. And we continue to consult and offer experience, but our goal has never been to say, take this model and put it in your country. It's here's what we do. You need to adapt it to what your country is. If they have socialized medicine in a lot of European countries, or if you're in the African countries, it's about getting access out into those underserved areas. So we've been really thoughtful about not forcing our profession and the model and say, you must do it this way. We're not copyrighted. This is what we do. You can adapt to what your needs are in your country.
You mentioned, Cindy, underserved and resource limited areas. So it sounds like the PA profession, whether it's addressing worldwide shortages of healthcare workers in underserved countries, perhaps in Africa, but we also have those issues here at home and a rural healthcare shortage. How big an impact is that having on solving that rural healthcare crisis that's such a big issue for people that just don't have easy access to healthcare?
I wish I could say we solved that. That was our original goal was, more rural areas. But today, underserved areas could be inner city, right? We see care there. Um, we've made a dent, but there's still need because there's more people. Science, the upside of science is that people live longer, but they are more complex. Older adults are more complex to take care of, so there's more people in the system. And we see today lots of PAs have followed the House of Medicine and are doing specialty care. But PAs are practicing in areas like telehealth, where we can get out to more rural areas, or, telehealth was just a boom in the mental health area, in the area of mental health and psychiatry, because you don't need to really do an exam every time you see them. A lot of it can be done through telemedicine. And that's really opened up a lot of opportunities for patients to get care, mental health care, substance use disorder care, from their homes or in their workplace, wherever it might be, without the stigma. So PAs have been able to kind of fill in that area. But there is still always a need, and we're always, as educators, trying to encourage our graduates to go into more rural areas.
It does seem like, telemedicine and phone-based or video conference-based healthcare delivery has really caught fire the last few years. I imagine, like a lot of things coming out of the pandemic, it just sort of forced mainstream adoption. And it seems like that is a great approach to solving some of the access issues. Do you see the PA role as being more of the front-facing healthcare worker that you're going to be interfacing with when you have a telemedicine experience versus an MD or a nurse practitioner? But is that sort of one of the main events for the profession in really starting to staff those telemedicine solutions that are becoming so widespread right now?
Well, I'll jump in with that
Yeah,
and
go
just say
ahead.
there's an example where the technology, as you say, has made such a difference, and the pandemic in particular. But we learned much the way, and this is true of all of business. How much work can you do from home, like we're just doing via Zoom? The answer is a lot. And so then various businesses that have nothing to do with health are experimenting with how many days a week do people need to be in the office, because when you think of the time of commuting, the cost of gasoline or electricity, all of that, and certainly, as Cindy pointed out, but it's particularly true in psychiatry, but I think it's true in general medicine. If you know a patient very well and you've seen them a number of times, if they are following up on a mental health issue, how are you doing on your antidepressant? A month later. You can do that really just as well as we're doing face to face. Saves the patient driving in. Maybe they're on a medicine that they shouldn't be driving, So there's a way you get care to people that you couldn't even do without having someone going out to their house as a visiting professional, visiting nurse, so I think the cost is going to go down with telehealth. And I think we're just beginning to get at telehealth. And I think then you look at AI, artificial intelligence, and I think more and more patients are going to be able to look things up and say, I've been reading about this blood pressure pill I'm taking, and I think I might have this side effect. So I looked at AI. Now, this could be backfire on you, and they could give you a 5-page report to read and say, but I think artificial intelligence is here, and I think we're going to be able to we also have mobile clinics. We've had mobile clinics for years. They're getting more and more sophisticated, where there are actually mobile X-ray and imaging centers that go out and do a whole array of imaging, from MRIs to CTs to a standard X-ray. And they'll come to your town, you make an appointment, you don't even go to the doctor's office. There's some downsides to that too, but in terms of convenience, tremendously helpful.
I was just going to say real quick, AI is undoubtedly going to have an impact across all of healthcare. And I know I've used it a lot for preventative types of healthcare recommendations, nutrition, exercise, living, a more healthy life. Let's just hope as more and more people ask AI for healthcare advice that, what do they call it? Hallucinations that
Yeah.
AI has, and throws it into the mix with actual legitimate results. You get the occasional hallucination. I'm sorry, Cindy, you were going to add to Dr. Sadler's comment.
I was just going to say, telehealth and telemedicine, um, certain parts of medicine are lent themselves to being done well by telehealth. You wouldn't want your child's meningitis being diagnosed, over the internet or over the phone, but that follow up on that child that you were kind of debating on, do I admit or not admit, or dialysis care where you're checking in. So to be honest, patients can get improved care because you might say, okay, I really want to kind of know about their blood pressure, but oh, I don't want to bring them back in a week because they're not going to come back. Oh, we'll see you back in 3 months or 2 months, where you can have that telehealth visit. The patient shows you their blood pressure readings over the past few weeks, and you can make those decisions. So we can keep tobacco cessation was another one where really you need that prompting. So that quick telehealth visit can really help those patients succeed. So there are certain areas where we're probably enhancing and improving the care we're providing to patients. We just have to be thoughtful. Dermatology is loving it because, using cameras, they can, diagnose rashes or follow up on things that just don't have to bring patients into the office, or their chance of they won't come, or, don't want to come to an appointment or whatever. But we just have to be thoughtful about making sure that we're not compromising healthcare with conditions that really need to be seen and examined in the office.
I want to ask a question of both of you. As healthcare practitioners who have witnessed the evolution of the industry and technology really take root in recent years as well, what advice would you give to PAs entering the profession today, and how best do they prepare to, keep pace with the rapidly changing world of healthcare that no doubt the PA profession will be at the epicenter? So let me ask you first, Dr. Sadler.
That's a great question, and it really applies to any health care profession. But specifically as it relates to the PA world, I'd say first, if you ask me that question and we're a PA, I would say you have the best profession of any in healthcare. And when the U.S. News and World Report and Forbes and some of these magazines do most popular, most successful professions, PAs and nurse practitioners are 1 and 2 on the list based on level of job satisfaction and work-life balance and those sorts of things. The first physician is often like number 19 on the list after physical therapy and a lot of others. So why am I emphasizing this so much is that you as a PA will have a chance to have a happy, relatively stress-free life compared to someone who's chronically exhausted, who's having to be on call at these hours that Cindy mentioned. And so frankly, I think the PA profession really has it. That's not to say you can't find your niche in medicine where whatever you're doing you love and it works out great. Same in nursing, nurse practitioner, all of the above. Some of the best diabetologists are nurse practitioners, my wife being one of them. So that's why I know for sure. And she's an expert at putting in the special kinds of pumps and monitors that she just learned how to do that really well. And that I might point out is over the years, and it's particularly true in surgical training, Cindy alluded to it a little bit with that surgical ICU story you told, where a PA is actually running and PAs are actually running the show as the residents come through. There have been these marvelous stories. I know one out in Seattle where a PA was in cardiology and then got into putting in pacemakers and then got so good at it that he was the go-to guy if you needed a pacemaker and for your heart. And he was not only teaching the house staff, the residents, but the fellows in cardiology how to put in a pacemaker, which is pretty special. But that, I think, reflects any other skill where you are and you keep up and you're at the kind of person who's at the cutting edge and want to learn and want to teach. And he was that kind of person. There are a lot of examples of PAs doing that across the country in different kinds of fields, particularly ones that have been in practice for 10 years or so.
And Cindy, what about you? What's your best advice for someone entering the profession?
So besides it is the best profession, just remember that it's a servant profession. We're here to serve our patients. Never stop learning. So I'm going to use my Angelou. I'll modify because I can never remember it perfectly. But, she said, people will forget what you said to them and what you did to them, but they'll never forget how you made them feel. And I always pride myself as a PA that our relationships with our patients are very near and dear to us and special. And so not to lose that. Technology is great. You just have to balance that. And then Maya Angelou also says you can't go through life with a catcher's mitt on each hand. You have to stop and give something back. And PAs have been known to give back, be in the community they serve. So it's not just in their safe space with their white coat, in the confines of a healthcare system, an office, a clinic, but we meet patients where they are out in the community and kind of get that whole picture of where a patient really is. So when we say walk in their shoes, we really do walk in their shoes. So make sure to give back into your community.
Well, this has been a great conversation. Thank you both, Dr. Alfred Sadler and Cynthia Lord. This has been very insightful, and it's clear that the PA profession has come a long way from its origins in addressing the healthcare shortage that it was originally concepted to address, to becoming a global model for collaborative and adaptable patient care. It's really inspiring to see the ways in which PAs are contributing to healthcare. And as we've heard, the future of the profession is really promising. For our listeners out there, I want to thank you for joining us. And if you're considering a career in healthcare or want to learn more about the PA profession, I hope today's episode has given you a new appreciation for the vital work that PAs do. And please check out Hawaii Pacific University's PA program. You can visit hpu.edu to learn more about it. It's the first homegrown PA program in the state of Hawaii. So we are excited to talk today about the profession, and I want to thank our guests today. And until next time, stay healthy and stay informed.